My name's Jacob. I'm a final year medical student at Lancaster Medical School. Welcome to part 7 of this cardiology series, where we're going to be talking about ECG interpretation related to P waves. Okay. So if you haven't seen my previous video about an introduction to ECG interpretation, make sure to check that out before you watch this video. With all that being said, let's get straight into it. So like I said, today we're going to be focusing on P-wave interpretation. In future videos, we're going to be looking at QRS morphology, T-waves, intervals, particularly the PR interval, its T segments, and also the QT intervals. Okay, but let's focus on the P-waves today. Okay, some things I want you to remember from the previous video. Okay, so I want you to remember that depolarization towards a positive electrode gives a positive deflection on the ECG trace. Okay, depolarization away from a positive electrode, so away from a positive electrode, gives a negative deflection. Repolarization towards a positive electrode gives a negative deflection, and repolarization away from a positive electrode gives a positive deflection. Okay. Right, so if we look here, we have the P wave, which represents atrial depolarization. Okay, and we can see that the P wave has a lower amplitude or height compared to the QRS complex. If we look at the R wave up here, it's much higher than the P wave, and that's because the atria have a lot less muscle mass. Okay, so there's going to be less electrical activity picked up by the electrodes. Okay, and there's a slight delay in left atrial depolarization compared to right atrial depolarization, and that's because we have the SAN located in the right atrium, and the impulse has to travel to the left atrium via Bachmann's bundle, which I'm illustrating here. Okay, so let's talk about P waves in terms of normal morphology and polarity. In terms of morphology, they're present in all leads. They have a duration of less than 0.12 seconds and an amplitude of less than 0.25 millivolts. In terms of polarity, they're positive in leads 1, 2 and AVF, negative in AVR, and biphasic in leads V1. Okay, so we have V1 here, and so initially we have a positive deflection because of right atrial activation, and then we have a subsequent negative deflection because of left atrial activation. And I'm going to explain this with a diagram very shortly. So here, right atrial depolarization produces the positive deflection in V1, and then left atrial depolarization produces the negative deflection in V1. Okay, so here we have a diagram of the heart with the precordial chest leads included. We also have a diagram what you might be familiar with from the previous video, which helps us to understand why waves have a particular deflection. Okay, so we have our negative pole, which is the negative electrode, which is going to be our reference point. We also have our positive pole, which is going to be our point of view. So remember, always looking. So on the heart, for example, so this is our reference point here. This is where we have our negative pole, and this is where we have our point of view. So we're always looking in this direction. Okay, and like I've mentioned already, when you have depolarization towards a positive electrode, that's going to produce a positive deflection. Okay, so if we think about it, so we're going to be looking at V1. Okay, so initially we're going to have a positive deflection because of right atrial activation. So the depolarization of the right atrium is going to occur in this direction, and it's going to produce the positive deflection because we're going towards that positive electrode. Okay, but when the impulse travels via Bachmann's bundle, and that's going to be traveling away from this positive electrode. It's going to produce a negative deflection. Okay, so that's why in V1 it looks like this. So you have that initial positive and then negative deflection. Okay, I hope that makes sense so far. Okay, so let's now talk about some P-wave pathology. First of all, we're going to talk about P-pulmonale. And the definition is when you have elevation of the P waves, an amplitude greater than or equal to 0.25 millivolts in leads 2, 3, and AVF. So you can see that the P waves, particularly in lead 2, look more similar to the QRS complexes because they have that increased amplitude. Okay. And we know that the etiology is due to right atrial strain. So why do we have this right atrial strain? Okay, so typically this is due to hypertension within the pulmonary vessels, and this can be primary pulmonary hypertension, where there's lots of different factors involved, or this can be due to secondary pulmonary hypertension, where there's an identifiable underlying cause. Okay. So there's lots of different causes of secondary pulmonary hypertension. So pulmonary embolism, that tends to be transient. So you might have some transient P pulmonale which resolves, but other respiratory disease which can cause right atrial strain, such as COPD, lung fibrosis, and even cardiac causes. So congenital heart disease, particularly where we have pulmonary stenosis, and even tricuspid stenosis. Okay, and that's where you have right atrial hypertrophy not associated with right ventricular hypertrophy. Because them other causes, such as COPD, you're going to have hypoxic vasoconstriction within the pulmonary vessels. There's going to be increased afterload, which that right heart has to overcome in order to maintain the cardiac output. Therefore, we're going to have a backflow or blood remaining within the right ventricle. Blood's also going to enter back into the right atrium, leading to hypertrophy and hence right atrial strain. Okay, so I hope that makes sense so far. So, essentially, we have slower depolarization of the right atrium. So, because we have right atrial hypertrophy, that leads to slower depolarization of the right atrium because physically there's more muscle mass, there's more muscle tissue. So this is going to overlap with left atrial depolarization because it's taking longer. So therefore there's going to be an overall increased magnitude of atrial depolarization, hence an increased amplitude or height of the P wave. Okay. And then just to reiterate definition, it's where we have an amplitude greater than or equal to 0.25 millivolts in leads 2, 3, and AVF. Okay, like we can see here on the diagram. Okay, so now let's talk about P-mitrale. In a way, you can remember that this affects the left atrium of the heart is because the mitral valve lies between the left atrium and the left ventricle. That's perhaps a good way to remember it. And what we essentially have, we have left atrial enlargement and hence left atrial strain. Okay. So we're going to have slower depolarization of the left atrium. Okay, and that's because of the left atrial hypertrophy. Okay, so there's going to be a longer duration of atrial depolarization, and this produces that bifid aspect of the P wave. Bifid essentially just means split, because if we look at the definition, we know that the definition of P-mitrale is you have a bifid P wave in leads 2, where the peak to peak interval, so the peak of each section of the bifid wave is greater than 0.04 seconds, or 1 small square, and it's also biphasic in V1. Okay, so the various conditions what can cause P-mitrale. A few of them are restrictive cardiomyopathy, for example. and that's typically due to infiltration of the cardiac tissue. That could be due to sarcoidosis, amyloidosis, other infiltrative disease. Okay, particularly in sarcoidosis, you have low voltage QRS complexes. You might also find some bundle branch blocks too. Okay. Also, it could be due to rheumatic heart disease. So this happens maybe 6 weeks following a Streptococcus A infection. Other signs might include skin changes. So you could have features of endocarditis, or on physical examination, perhaps a murmur, which you could listen to. There might be signs of polyarthritis, neurological signs. There's a condition called Sydenham's chorea, where you can have involuntary movements of the limbs and the face, particularly facial grimacing, or even you can have causes such as constrictive pericarditis. Okay. And I just want to reiterate the pathophysiology, and this is lead 2, by the way. So we have left atrial enlargement, so we have slower depolarization of the left atrium, a longer duration of atrial depolarization, so increased duration of the bifid aspect of the P wave. Remember, in V1, it's going to be it's still going to be biphasic because of the direction of depolarization of the left atrium. It's away from that positive electrode, or the positive pole of V1. Okay, so I hope that makes sense so far. So essentially here we know that this first bifid part of the wave is related to the right atrial depolarization, and then because we've got that left atrial hypertrophy, it almost like separates, and that represents the left atrial depolarization. Okay, because of that left atrial hypertrophy. Okay, so I hope that makes sense. I know it's quite a complicated topic. So let's talk about P waves in terms of P-bi-atriale. Okay, so this is when we have a combination of left atrial and right atrial enlargement, and there's lots of different things what can cause this. Okay, but I want you to remember it's biatrial enlargement. So you could have underlying mitral valve disease, aortic valve disease. So it could be stenosis, regurgitation, chronic hypertension, hypertrophic cardiomyopathies, and any other causes of left atrial strain. Okay. And we're going to have slower depolarization of the left atrium and the right atrium. And then we're going to see basically, essentially what it is a combination of P-mitrale and P-pulmonale in 2 or V1. So we have lead 2 here and V1, and we can see that we have this combination of mitrale, so the M-shaped wave, and we can also see that we have an increased amplitude as well. So that's related to that pulmonale. Okay, so it's a combination of mitrale and pulmonale, and because of that left atrial and right atrial enlargement. Okay, so that's everything in this video today. I hope you found it useful, and I'd really appreciate if you could stay tuned for the next video, where we're going to be talking about QRS morphology in more detail. Okay, so if you found this useful, leave a like, give it a like, leave a comment, and don't forget to subscribe. You know, I really appreciate any feedback I can get. So yeah, that's everything. Take care, and I'll see you in the next video.